My name is Radhika. I'm one of the endocrinologists over at the Seattle VA. I'm also faculty at the University of Washington in their endocrinology, diabetes, and metabolism division as assistant professor. And so what do? I'm a clinician educator. I see a lot of patients in endocrine and diabetes clinics. I'm also the site director for the fellowship program at the VA. And so all the trainees who want to become future doctors, future endocrinologists who come through there, I'm in charge of their educational experience and their rotations. And then the other thing is my clinical and research interest is osteoporosis and bone health. And so I see patients every Wednesday, myself, an endocrinologist, my colleague who's a rheumatologist, and my other colleague who's a geriatrician, meaning a doctor who sees patients that are above the age of 70. We all see patients for bone health. And we have a pharmacist dedicated to us who knows how to give advice to patients on how to take these medications, osteoporotic medications. And we also have a physical therapist and an occupational therapist in clinic with us. And you'll understand why this clinic is set up like this, hopefully by the end of the talk. Okay, so it's a multidisciplinary clinic that we all work together. And there's a lot I can talk about in terms of osteoporosis and what is it. But what I wanted to focus on and educate everybody on today is, what is this word, osteoporosis? How many of you in the room have heard of this word? Okay, great. So maybe I'll go very fast on that. But I want to talk about it and make sure you all understand when I say osteoporosis, what does it mean? And talk to you also then about what causes this osteoporosis. And really divide it up into risk factors for bone loss and also risk factors for falling. I am not going to do justice to you if I only talk about bone loss and give you a medication for osteoporosis, but not ask you, are you feeling safe at home? I'm not doing justice. So it's really a two-pronged approach. What are your risks for bone loss? Are you falling? And then the other thing is, I'm just going to give you a glimpse of what are the tests that your doctor may do to help you diagnose osteoporosis. And then finally, I'm going to focus on what everybody in the room, cancer survivor or not, can do to prevent bone loss or falls. So I'm going to end with really talking about key points about calcium, vitamin D, and which exercises really help maintain leg strength, balance, and posture. So just to make sure we're all on the same page, what is osteoporosis? So a lot of patients think it's osteoarthritis when I talk to them about osteoporosis, and I have to correct them. No, it's not that knee problem I'm talking about. This is a skeletal problem where your bones are thinning. They're actually porous, so it's in the word definition. And here, take a look at this picture. You've got this whole meshwork or framework. This is a picture of your bone. Yeah, it's made of collagen, proteins, calcium, phosphorus, all of this coming together to support your skeletal system. This is a picture of osteoporotic bone, thinned down. The spaces are widened here, right? Much more fragile. This mechanics is at a risk for a fracture if you were to fall. What's a fracture? A major break in one of your major bones. So I'm talking about the spine, the vertebrae. I'm talking about the long bone, the femur it's called, or the hip, okay? And why do I care about those bones? Because what are these words that doctors use, morbidity and mortality? Your risk for dying, and your risk for not being able to independently live, function, do any of your daily activities is quite high, especially after a hip fracture. So that's why I care about this. And again, it's not just the density or the numbers, which we'll talk about. It's also the quality of your bone. You know, what's the mineralization look like? What does the structure look like? So all of these really go into your bone strength. The other thing I want to mention is as we get older, all of us will lose bone. So age is going to be a risk factor for bone loss. And when you're young, you're a kid, you're in your 20s or 30s, that's when you're gaining that peak bone mass. But then what happens is, for the women in the room, you hit menopause. You lose your estrogen. The key message here is estrogen for women and testosterone for men are very important sex hormones for bone health. Unfortunately for women, we have menopause and then boom, that estrogen's gone. So the bone loss is quite rapid. But men also can get osteoporosis. The loss sometimes that men have in testosterone isn't as profound as women, but it happens. So that's the key message to remember here. The other thing is, bone is a living tissue. There's this constant remodeling happening where it's repairing. And I use the analogy of the construction workers. So think about it. You have a crack, okay? Then you get these bone cells called osteoclasts, which come in, kind of create a pit and drill out everything. And then the osteoblasts are your bone-forming cells that come in and lay down all that new bone. So this is what happens when you have kind of a micro crack or something that causes some strain in your bone. And unfortunately, with age and other risk factors, which we'll talk about, this can tilt more towards bone loss and increasing how fragile and how porous your bone becomes. Before I kind of talk to you about those risk factors, though, I got to show you that this is a public health concern. It's just not talked about. And that's the problem. After you've had the fracture, maybe people will talk about it, but we got to talk about it before you have the fracture. Because 2 million people have osteoporotic fractures, major fracture in one of your major bones every year. 1 in every 2 Caucasian women and 1 in every 5 men will have a fracture. I say Caucasian because some ethnicities and racial backgrounds have a higher incidence of osteoporotic fractures, and we'll talk about sometimes genetics plays a role. And then I've told you that there are deaths that can happen from a hip fracture, and a lot of people have to then go into a nursing home or a long-term care facility because they're just not able to keep up and stay home independent. So this is why I tell you it really is a crisis, and that's why I'm here to really kind of educate everybody on it. It helps to sometimes put some famous faces to this osteoporosis. And so Sally Field, we all know, Mrs. Doubtfire, she actually had osteoporosis. She was actually also on some commercials for one of the medications for osteoporosis. Unfortunately, I'm not going to talk to you about all the drugs because that in itself is going to be several hours, so I chose not to talk about that today. Meredith Rivera from the Today Show, she actually has something called osteopenia, which is low bone density, and we'll talk about the differences in a little bit. But she's also a spokesperson for bone health because she has a family history of osteoporosis. Men get osteoporosis too. We all know the unfortunate story of Christopher Reeve. His horse didn't jump with him, right? And he breaks 2 of his cervical vertebrae and has something called a spinal cord injury, right? And he's in the wheelchair. Spinal cord injury patients, they don't move their legs, sometimes their arms, yeah? And they can get complications from the injury. And one of the complications is bone health or osteoporosis. Jimmy Carter recently just had a hip fracture, 90 years old. He fell in his Georgia home. A lot of times that's how it happens. You fall at home. So this gets to everybody. Finally, a lot of patients ask me about this, so I included this. My grandma, my own grandma, had this hump. Yeah? A lot of us know people who have this hump, right? What is it? It's called Dowlinger's hump, and it's the curvature of part of your spine called the thoracic area. There's various reasons you can get this. Genetics. You can also get this if you lose the cartilage in between your discs. But another reason is osteoporosis can be a silent disease. A lot of times, yes, you fall, you have pain, boom, you know you've done something. But a lot of other times, you don't even know you've broken one of your vertebrae or things like that. So that's why I'd say it's a silent disease. Moving on, so as I mentioned to you, There are two components to osteoporosis that we talk about in our clinics. It's not only about looking at the individual person in front of you and saying, these are your risk factors for bone loss and continuing bone loss, but it's also, what are your risk factors for falling? Because I can do everything and give you all the medication, but if I don't decrease the chance of you falling, it doesn't help, right? So we're going to talk about both aspects today. A long list, right? Long and daunting list of all the things that goes on in your doctor's head about what are the risk factors for you losing bone. And it's quite long, and, but I want to hit some key points. 1, genetics. Did your mom or dad have a hip fracture or osteoporosis? We don't know what genes. We're looking into it, but there is that propensity if you have a family history. Second thing is like I mentioned to you, right? The sex hormones are important. So if you are postmenopausal or you have something called hypogonadism where you have low testosterone, that can affect your bone health. Malabsorption. So if people have gastrointestinal disorders that affect their absorption of their key nutrients, okay? Or you have diarrhea, chronic diarrhea, that can do it too. And a lot of medications treated for other reasons can also affect and cause bone loss. And while a lot of this list you can't change, we can't change, what are things you can change? These 4 things. We're going to talk about calcium and vitamin D intake at the end, so I'll come back to that. But the 2 other bigger things that I want to mention is alcohol and smoking. Smoking and the nicotine affects those bone cells that can speed up the bone loss, the osteoclasts. And so we really encourage patients to kind of slowly at least cut down. If you've quit, great. But if you have a very significant pack history, I put that in the back of my head. The other thing is alcohol. Through various complicated pathways, including, you're drinking so you're not getting the right nutrition and so forth, alcohol affects bone loss. So, and also it's a risk factor for falls, right, guys? So these are the things that everyone in this room, cancer survivor or not, can really change. Speaking for the cancer survivors in the room today, a lot of you, you had to fight cancer, you had to go on those chemotherapy agents. But just to educate you, there are side effects and there are things you should be aware of. A lot of you, when you had to go on those chemotherapy agents, had to also go on, what was tagged on in your regimen was something called steroids, prednisone, methylpred, corticosteroids, so many names. The steroids, they accelerate the osteoclasts, those bone losing cells, right? So you needed it, but that's unfortunate, the side effects. So I just want you guys to be aware today. The other thing is, as you're fighting cancer and you're on these chemo drugs, you don't have appetite, you lose weight, you don't eat, your nutrition isn't great. That factors in. And then finally, I've told you these sex hormones are important, right? For the breast cancer survivors who had estrogen-positive breast cancer and the prostate cancer patients who had to be on androgen deprivation therapy, the doctors had to block the estrogen and the testosterone, right? That affects your bone health too. So these are some of the things that for cancer survivors are increased risk factors. So moving on, falls. We've got to keep you safe. Otherwise, we're not really helping you to try and prevent that fracture. And there are a lot of things that can kind of accumulate and add to your risk factor for falls. You may have diabetes and you're having low blood sugars, right? You get dizzy with the low blood sugar and you may trip and fall. Or you have blood pressure issues and your blood pressure is going high, going low. Low is not great, right? Or you may have neuropathy. The chemo agent or the diabetes gave you neuropathy. You don't feel things. A lot of patients tell me my legs give out, right? Or you've moved in with your son or your daughter because they're going to help take care of you and their toilet seat's too low. I stumble to get down onto the toilet seat. Or there's no grab bars in the shower in case I was to trip. These are all things we should be thinking about. What can we do to minimize these risks? So let me ask the audience in the room, and you don't have to raise your hand if you don't want to, just take a moment to think. But these are some of the few questions I ask my patients. How many times have you fallen in the past year? Are you feeling unsteady when you walk? Are you scared of falling? If you've answered yes or more than once, that is a conversation you should start having with your doctor, okay? We do this all the time, and we give out questionnaires actually while people are waiting in the waiting rooms and it is an eye-opener for a lot of my patients because no one really thinks about this. Yeah, go ahead.
Which doctor?
You could be your primary care doctor. It could be, you can mention it to your cancer doctor because they sort of take over your care, right? During that time. You just have to tell somebody and then they can kind of get you to the right place.
Thank you.
Yeah, of course. And so what can you change? Certain things you can't change, right? You can't change the diabetes. You can't change the blood pressure. You can't change the neuropathy. But you can change your lower extremity strength and balance and try and improve that. And so we'll talk about that. So moving on, how does my doctor tell me, or how do we find out we have this? She said it was a silent disease. So one of the tests that we have, and it has our limitations, it's not the greatest test, but that's all we got, is something called a bone density scan. Anybody in the room had a bone density scan? Great. Oh, wow. This is the opposite of the first room. So it's kind of like an x-ray. The tech positions you in different ways. And it gives you a printout of the pictures of either it takes pictures of your spine, it can take pictures of your forearm, hip, or your long bone. And what it's looking at is something called a T-score, where it looks at your bone density, and it says, how far away are you from the young adults, the mean average young adults? If you're really, really far away, that's osteoporosis. And that's that T-score of -2.5. If you're somewhere between -1 to -2.5, you have something called osteopenia, or low bone density. And then if you're not too far away, you're okay. Again, this is only telling me density. It's not telling me quality. So that's why I want to emphasize, this is just one part of it. It's not the Bible. The other thing I do with patients when I have them in the room sometimes is this called FRAX, Fracture Assessment Risk Calculator. So it takes into account your bone mineral density at the femur. So it doesn't take into account your hip or your spine. And then it asks you a few more questions. So it asks your weight and your height, because everyone has a different weight and height, right? It also asks, are you still smoking? Are you on these steroids? Did your mom have a fracture? So it asks you a few more things, and then it calculates your risk for having a major osteoporotic fracture in the next 10 years, and your major risk for having a hip fracture in the next 10 years. If the percentages are above 20 and above 3 for the hip, 20% for the osteoporotic fracture, then your doctor should consider treating you, okay? But again, it has limitations. You can't do this if you're already on an osteoporotic drug. It only accounts for one bone mineral density in one area. It's limited to only 4 racial backgrounds: Caucasian, white, black, and Hispanics. And so it's got its pros and cons. So who should get a bone density scan? That's a great question. And the guidelines that the different doctors follow are all a little different, which makes it really hard and challenging. They're not talking to each other. They're not coming up with one unified consensus on these are the people you need to screen. I've made this slide where it kind of involves a couple of the guidelines, and this is sort of what we practice at the university. So if you're above the age of 65 and you're a woman, men above the age of 70, that is a little controversial, so I will put that up, say that. You should get a DEXA. If you're between a certain age and you have other risk factors, so like you have cancer or you're on steroids, you should get this. Or if you're 46 and you had a hip fracture, unless you fell from a building or you shouldn't be having a fracture at 46, right? If you just sat here and you fell and you had a fracture, there's something going on. So those patients should also get a bone density scan. And then after that, your doctor will do a bunch of blood work and urine tests. I just mention it just to make you aware. It's putting it all together that comes up with this diagnosis of you being treated for osteoporosis, so it does require several steps. Okay, so now we're going to talk about what are things that everybody in this room can do to change their risk for bone loss and their risk for falls. So I'm going to focus now on calcium, vitamin D, and your exercise. So I grew up with the Got Milk ads, so I liked The Simpsons and I liked Friends, so I put these of the two up there. What I want to say is calcium is not only important for your bones, but it's also very important for your nerves and muscles to function, okay? But does that mean if I just keep taking calcium, it's good? No. There's only so much that can help your skeletal system and that the bones take in. The rest is going to be excreted. It's either going to come out through the GI tract, your gastrointestinal tract, or through your kidneys. So the kidneys have to filter all of that extra calcium. And so I say this because too much calcium isn't good for those kidneys. It can put you at risk for kidney stones if you have a lot of calcium in your urine. And the calcium can build up in your blood vessels. Okay? So what's the right amount? About 1,000 milligrams every day is what's recommended of calcium for bone health purposes. And so how do I get that? Well, I usually ask my patients, based on the American diet, how much cheese, milk, and yogurt are you getting every day? Typically, your milk, your cheese, and your yogurt have about 200 to 300 milligrams of calcium. So what I tell patients is if you can do a yogurt for breakfast, I know we all love to skip breakfast, including myself. Usually people do sandwiches for lunch, right? So a slice of cheese or two. And then a glass of 8-ounce milk at dinner, you're pretty good. For the lactose intolerant patients in the room, there are products that have the calcium added that is more gentle on your stomach. And so I mentioned that. I also mentioned lattes are good, okay, for the GOT fans in the room. This is for my husband. But there's also a lot of other vegetables and beans that actually provide calcium. And so my slides will be available. This is the National Osteoporosis Foundation website. They actually have a nice patient portion. And they have a long list that's in blue of the different foods. But one thing I just want to mention, I said here fortified orange juice has calcium in it, right? So this is right outside. I looked at it. Calcium, 0. You've got to read the labels, okay? Not all orange juice, just because I put it on the slide, will have the calcium. So I literally went and picked this up and brought it in. I was like, this is perfect demonstration for this. So how do I read the labels, doc? Well, it's confusing, right? Because they have this bottom thing that usually says percent value, right? So here it says 20% calcium. Add a 0. You'll get the amount, 200 milligrams. So on this Tropicana one, it just said 0. It actually had your milligrams as well as percentage. So some of them do it, some of them don't. But this one said 0. If you absolutely can't get your milk, your yogurt, your cheese, my cardiologist said, don't eat too much cheese, doc, or I have diabetes, I have to watch the carbs, then I say supplements. But again, supplements have side effects. One thing is the calcium carbonate form can cause constipation, okay? And that's not always good for my cancer survivors, right, who are on pain medications. They're already battling with constipation. So I really, really do try and I try and encourage my patients to get it through their diet first, but if not, we talk about supplements. I usually say take them with food. And then the other thing is please, please read the labels. The supplements are not FDA regulated. They are not. So one bottle can have one dose, another bottle will have a different dose. All right, moving on, vitamin D. There is a lot out there on vitamin D, and it's confusing. but I'm going to just touch base on key points. What does vitamin D do for my bones? Vitamin D actually helps the calcium get absorbed in the gut. That's what it does. So that it brings in that calcium that you need for the mineralization of your bones. That's its real job when it comes to bone health. And I'm going to show you this weird pathway with all these funky names. But I'm trying to show you this is complicated. And I'm trying to show you vitamin D is a hormone. People don't realize that. It's a hormone. Too little is not good. Too much is not good either. So that's the key thing. So how do I get vitamin D? I get it through food, and I also get it through the sun, right? You have a steroid hormone in your body that needs the UV light to activate it. And so then vitamin D goes through all these pathways where first it's like something called a precursor, and then finally the liver gives an enzyme to it, as well as the kidney gives an enzyme to it, to actually finally get active vitamin D. So I show you this to show you your liver needs to be good. So if you are drinking a lot of alcohol that's affecting things, this pathway can be affected. And then if you have kidney issues or you have diabetes and kidney problems, this pathway is affected too. Okay? So I just highlight to you that your body, it's a very complicated system to get vitamin D working, and it's a hormone. So be careful. So when I say be careful, why am I saying that? Because, a lot of patients come to me and they say, I read that vitamin D helps prevent heart attacks, or vitamin D helps prevent this or that. There's a lot of research still going on about it. What does vitamin D exactly do? But I know they didn't ask it to show much research, but I'm going to show you one research article that came out at the end of last year. It's from the New England Journal of Medicine, which is a prestigious journal article. And they actually asked this question. If so many of these patients, and it was a lot of patients, if they took vitamin D every day, and then these other patients took a sugar pill or something called placebo, does it make a difference in terms of the rate at which they have cancer? And they looked at prostate cancer, colon cancer, breast cancer, or does it help prevent heart attacks or strokes? And I don't expect you guys to understand all of this, but here's the key message. You see, this is cancer. This is heart attacks and strokes. Placebo is sugar pill. Vitamin D is vitamin D. Do you see how these lines are exact? Exact. No difference. Vitamin D, taking vitamin D every day did not help decrease your risk for any of these. This study is ongoing, and they're looking at different things. And there are other studies looking at it, but I just wanted to show you it's a real gray topic right now. But it's not really showing the benefit of this. And I know a lot of patients who come and ask me this, so that's why I wanted to show it to you today. And so what are the key things to remember? It's a hormone. There's a range. And when you go and get your vitamin D checked, and your doctor gives you a printout and gives you a reference range, right? A lot of labs have a wrong reference range. They have it from 30 to 100. If your vitamin D level was 100 or 98, I'd be calling you and being like, what are you doing? That's too much. You're at risk for spilling a lot of calcium in your urine, right? So there are side effects if you try and get it too high. And so what is the recommended level? Most of us bone health experts will say your vitamin D level should be about 20 to 50. And in that study, most of the vitamin D levels were about 33. So right there. So that's the real key things to remember about vitamin D today. So finally, I'm going to end on exercise. Every doctor you hear says you got to exercise. I want to tell you why, for bone health purposes, you should exercise. So there's a very complicated pathways, but basically, some strain on your skeletal system is good. Not much that you're going to break a bone, but some. And what is it doing? Through these complicated pathways, it's actually promoting those bone-forming cells. So that's good, right? Yeah. So that's why I say exercise is important. But what exercise am I talking about? I'm basically talking about where your bones are supporting your weight. That's the key thing. So walking, dancing, low-impact aerobics, these are the good things. I'm not talking weightlifting. I'm just saying do some reps. Do some reps. Build up just some muscle strength. Doc, that's confusing. So I'm going to show you some videos. Where I got these videos was from the Osteoporosis Foundation in Canada. Their website is also really good. And they have all these series of videos that are actual people who've had a fracture or had osteoporosis and how they're dealing with it and how they're trying to say, I'm going to stay independent. Okay, there's even a 90-year-old that's quite inspirational, and she's doing these exercises and everything. So I'm going to show you two videos. One is Gary, who had prostate cancer, and what he does. And then I'm going to show you Mira, how she incorporates it into her daily life at home. Okay, so I'm going to show you two different people and have you guys take a look at what the kinesiologist in the videos is a Canadian term for basically a physical therapist here, and what they do to help these patients.
Were over after being treated for prostate cancer and suffering bone loss as a side effect. This put him at moderate risk for fracture, which would be increased by the bending and twisting during his regular golf game. However, in addition to taking the medication his doctor prescribed to prevent fracture, at moderate risk for fracture, which would be increased by the bending and twisting during his regular golf game. However, in addition to taking the medication his doctor prescribed to prevent fractures, we helped Gary implement a weight training program and made some changes to his game, so Gary can continue golfing for now. We'll begin with a half squat in a lunge with weights on either side. Squats in a lunge position will help build the strength in his legs to keep him able to move around the golf course. Start with feet hip width apart, holding one weight in either hand. Tighten your stomach muscles, as if someone was going to punch you in the stomach. Take a big step forward with one foot. Keeping your front knee behind your toes, bend both knees. Go down about halfway.
How many of you
Keep your back straight.
Anybody?
Push through your legs to stand up. Do 8 repetitions on each leg and progress up to 12 repetitions. The last few repetitions should be challenging. Next, we'll help Gary get to the floor safely in order to learn the plank exercise. Sometimes it's not the exercise, but how we get into it that puts us at risk. It's important to get down to the floor safely. Take a big step forward with one leg. Gently lower your knee down to the ground into a kneeling position. Bring your leg back to join the other one so you are on both knees. Hinging at the hips and keeping your back straight, bring your hands to the floor so you are on your hands and knees. Walk your hands forward and lower yourself down to the ground through a push-up so you are lying on your stomach. To stand up from the floor, you will reverse these steps. Planks will build core stability to help protect Gary's spine throughout his golf game and everyday activities. Start lying on the floor on your stomach, resting on your elbows.
How many of you can do a plank?
Push through your feet to lift your hips off the ground.
Good.
Tighten your stomach muscles to protect your lower back. Keep a straight line from your head to your feet. Don't let your bottom sag down or stick up in the air. Hold the plank position for 5 seconds. Gently lower your hips down to the ground. Don't collapse down. Rest for 3 seconds, then repeat the plank position. Repeat this 5 times. As you get more comfortable, hold the plank for 10 seconds and rest for 3 seconds.
So some of you in the room will say, I'm not Gary. I can't, do all of this. I can't go to the gym. I mean, I've got things to do. I've got kids. I've got grandkids. Well, here's Mira to contrast that.
In the last video, we met Mira. She is 73 years old and has a very active social life with family and friends. Mira's doctor told her that she had a spine fracture and diagnosed her with osteoporosis. The doctor said she had to be careful moving around. Mira was worried about how it would affect her life and did not want to be a burden to her family. The doctor recommended that Mira get more exercise, which wasn't something that she had ever done before, and directed her to the Osteoporosis Canada website. Mira found the Too Fit to Fracture booklet and learned how she could incorporate simple exercises into her daily life. Getting started was easier than Mira thought. she began to pay attention to her posture during daily activities, like how to put on her shoes. Mira started by crossing one foot over the opposite knee, bending gently forward from the hips to tie her shoes back straight. Also, she learned that it is important to bend at the hips and not the spine when getting things out of the dishwasher or lower cupboards. When sweeping, she turns her whole body rather than twisting her spine.
Clean house, right?
To add exercises to her daily routine, Mira stands on one foot while brushing her teeth, alternating feet in the morning and evening. While waiting for the kettle to boil, she does 2 sets of 12 heel raises, making sure the counter is nearby in case she needs to hold on for support. In the evenings, while she watches TV, Mira will get up and do 10 to 12 squats during the commercials. Standing with feet shoulder width apart, back straight, and eyes forward, she bends her knees and hips and pushes her hips backward as if going to sit in an imaginary chair. Because her knees bother her sometimes, Mira doesn't go all the way down. Keeping knees over ankles, she does not allow them to go beyond her toes, pushing back through her heels to get back to standing. Each afternoon before dinner, Mira takes 5 minutes to lay on her back with her knees bent to unload her spine after a busy day. Mira does an exercise called the arm and leg lengthener. First, she extends her arm over her head. Then, she takes a breath and lets her shoulders fall into the floor. Gently, she extends her arm as if there were a treat just out of reach, holding for 3 to 5 seconds, then bringing the arm back down, repeating 3 times. For the leg lengthener, she slides one heel down until the leg is straight, then lengthens her leg by pushing through her heel, almost as if pressing into an imaginary wall. Performing these exercises every day helped Mira create a good habit that is already helping to produce.
So I wanted to show you actually rather than just tell you. So hopefully this gives you an idea of some of the things that everyone could be doing and incorporating. You can go to the extreme of Gary, or you could do something like Mira does. We all brush our teeth, we all watch Netflix, right? So I'm gonna end there, and hopefully that's given you an idea and a sense of what everyone in this room can do to help themselves in terms of their bone health. And so I'll end there, and I'm open for questions.
Can you go back
Oh.
one slide?
Yeah. This one? Okay, so this is actually from my osteoporosis clinic. This is from my nurse coordinator. This actually, I'm gonna have the slides available, and so this is gonna be in there. This is what we give to our patients. It kind of talks about some of the things, and so one test I do for patients is I ask them, are you able to get out of that chair without using your arms? Simple thing, but a lot of patients can't, okay? And so one thing to do is just sit to stand. You can use your hands if you need, but all I'm asking you to do is sit and stand and do reps. It's a little tiring when I even do it. The other thing is tandem stance. Can you just even do this? Can you walk like this in a straight line? And don't worry if you can't. I know a lot of people who can't. So those are things that you can slowly build. The standing on one leg while you're brushing your teeth, that's perfect. You're trying to build these legs muscles. That's what you're trying to do. Because a lot of times what happens is these kind of wear down, or something we call atrophy, for various reasons, especially in the cancer survivors who've been on the steroids. So we're trying to build this up. So that's what these exercises focus on. Yeah?
Do you have any specific advice for people that have been on long-term steroid therapy? How would you change your advice, if at all?
I wouldn't change. I mean, I would tell you, you probably, if you're on long-term steroids at a certain dose, okay, I'll give you that caveat. It's about prednisone of 5 milligrams, and if you've been on it for longer than 3 months, and you know, that is someone that is at higher risk for having the thinning of the bone, and they probably should have a conversation with their doctor about having a DEXA scan and looking at it. And if they don't have osteoporosis, at least they should be getting their calcium and vitamin D that we've talked about. Calcium, at least 3 servings, 1,000 milligrams. Vitamin D, keeping it at that level of 20 to 50. And for everybody in this room, they should be doing have that ability to at least incorporate some of these exercises in. So I wouldn't change it. I would change it if you had osteoporosis or if you've had a fracture, but I didn't talk to you about all the drugs today, so. Yeah.
Question, so I'm taking vitamin D3 during the summer months, or if you're going on a vacation where there's a lot more sun, do you decrease your dosage because of the amount of D?
Yeah, that's a great question. There's so many factors to that. It depends on how long you're out in the sun. I mean, they've done studies in Hawaii surfers who are always out in the sun. And that's where this value of 20 to 50 comes. Usually the vitamin D levels were this level. And so there's a lot of factors to that. Also with the sunscreens, with all of us wearing our protective gear right now, right? You've got the hats that cover up everything. It's hard to say. Usually what I tell patients who are saying, I'm going to India or I'm going to like Africa for 3 months where it's really hot, I tell them, let's just check your level now and we'll check your level when you come back and we'll see where it is. I have patients who have to go on very high doses of vitamin D to build up their vitamin D stores. But after that, I bring them all down to a certain level. There are some patients I can't bring down, like patients who have had gastric surgery, bypass surgeries, and they just don't absorb things. So it's a little difficult. I would have to individually tell you guys, but usually it's okay. Yeah, go ahead.
My doctor just took me off a aromatase inhibitor because of what my nexus showed. I'm not osteoporotic, but very, very close. Without the aid of a drug, will my bone replace itself?
Bone replacing yourself. That's a great question. It just also depends on, are you on other things that could be causing bone loss? At this age, it's very hard to regain bone mass, okay? You could only prevent further bone loss, and that's how I said it, but building up the bone is tough. But you could build some bone with, kind of some strain with muscle and exercise, but really trying to reverse it is hard unless you use one of the osteoporotic medications. Yeah?
You had a slide where you were talking about the things that could lead to bone loss.
Yes.
And way at the bottom it said antacids.
Yeah, so
Are you
antacids.
talking things like Tums, for example?
I'm talking about like Tums. I'm talking about Tums has calcium in it, but I'm also talking about all of these over-the-counter, things that you can take for heartburn, because a lot of them affect calcium absorption. Okay. And so I know in the past, a lot of patients would just be on this and then it would always be on them. But I think now my colleagues and other doctors are trying to get you off of these medications. So it's just a conversation to have, do I need to be on this still? So that's another thing. But a lot of times patients will come on and they've just been on it and on it and on it. So yeah. Go ahead.
When you were talking about testing for vitamin D levels,
Yes.
on your slide you showed D250H. Are there different?
Yeah, so vitamin D is confusing. They have so many names, so many names. I usually have to tell the trainees, like there's so many names, you gotta be careful what you're prescribing or what you're ordering. What I'm looking for is vitamin D 25OH, hydrogen oxide. So that the doctor will probably order for you, but it's just so many names, so many forms, it can get confusing for my patients, so I just wanted to highlight that it is confusing. It's even confusing for the trainees and the medical students. Go ahead.
They then show different levels depending on the test that's being done.
So that's the different levels, it depends on which lab you're getting it even checked. The one that you want to check is the 25D level, not the 125D level. And so usually you want the 25D, and the reference ranges are all different, but typically for bone health, we're looking for a level between 20 to 50. Yeah.
About somebody that has bone metastasis like I do, anything that you would change for bone health or just kind of the same thing?
Bone mets is a risk factor. It just depends on where the location of the bone mets are. I would usually then tailor what exercises you can or can't do based on where the locations are. So for example, I have patients who have had several wedge compression fractures in their spine. I tell them you can't lift a certain weight. And I'll write a note for I have a guy who works at Home Depot. I wrote a note for him. He can't lift more than 20 pounds. So yeah.
I know you said you weren't going to talk about medication.
Yeah,
but I do have a question.
sure, go for it, yeah.
So my doctor did what she wanted to get a baseline. And
Baseline DEXA?
Yeah.
Okay.
And it turned out osteopenia, so they said that.
So low bone density.
They said they were going to give me a shot that was going to make me very ill.
Okay.
And I just wondered why that would be.
Okay. So I said, you know, the DEXA is not the Bible. And so sometimes I do have a subset of patients who have T-scores that are osteopenic, but the risk is high, and so that's when that FRAX comes in. And that's when I may have to consider treatment, okay? So it just depends on each individual. This is a very individual-focused treatment plan.
Why would
The shot make you ill?
Yeah.
So there's 2 shots, okay? There's one that builds bone. It's called teriparatide or Forteo. It's a daily injection every day, like insulin, okay? So I don't know which one they were talking about. The other one is Prolia or denosumab. It's an every 6-month injection that you have to take. The side effects of that medication is that if your calcium and vitamin D isn't good, it can cause low calciums, so that's a big side effect. It doesn't really cause muscle pains or weakness. That's not the one that's majorly listed as the side effect. It can cause sometimes a rash or like a skin infection if you're immunocompromised or something like that. But it doesn't make you sick per se. The other one they may have been talking to you about was IV zoledronic acid, which is an infusion you get once a year. The side effect of that is in 24 hours you may feel like you're getting the flu. So shakes, chills, nausea. So that's why I'm thinking maybe they were thinking that. But it's not you getting the flu, it's the medication going into your bones. And so it's not the flu, it'll subside. I didn't talk about medications because I could talk about it for hours. The side effects, the different profiles and everything. And I wanted to really kind of focus on calcium, vitamin D, and exercise today. So that's why I didn't, but I'm happy for questions.
You didn't mention walking, and I kind of thought if I do a brisk walk,
It's in there.
I don't have to do all this stuff.
Walking is good. Walking is good. Again, you're putting the weight on your bones, so that's great. But also, walking can only build so much muscle strength. So that's why just incorporating a squat or something else would also help. Yeah, and that's why I showed Mira as well, because Mira is pretty much all of us, right? Gary is, the gung-ho, but I think if we kind of do what Mira does too, that will help.
Is there benefit to doing the exercises in the pool?
Yeah, so that's a great question. So swimming takes the weight off your bones. So if you love it, do it. But swimming and cycling, you're taking the weight off your bones. So it doesn't help the bone health per se. But if you love it, do it. Okay? Other questions?
Did you say it doesn't?
It doesn't help the bones because you're taking the weight off your bones.
Okay, gotcha.
Yeah.
Less impact.
Yeah. Would be okay, yes. It's a tailored approach, and so I just listed a few. But the elliptical, you are putting some weight on your bones as you're pushing in and things, so yeah. Thank you, guys. You are great.